Thank you for the kind invitation here. Well, the pulmonary hypertension in the post-op period in cardiac surgery is a very detrimental problem. It's difficult to treat, but moreover, it's difficult also to understand which are the patients that can develop in the post-op period the condition of pulmonary hypertension. Well, there are many factors that are associated with developing pulmonary hypertension in the post-op. Mainly are associated with the preoperatively condition, with the pathology conditions such as increased pulmonary blood flow or pulmonary venous obstruction. Or condition related to the cardiopulmonary bypass effect itself. And all these are worsened or triggered by other conditions that can be prevented or treated, such as hypoxia, hypercarbia, acidosis, and pain. Talking about the first two conditions that are related to the cardiac pathologies, there are a list of common pathologies, congenital pathologies that are associated to the probability to develop in the post-op the pulmonary hypertension condition. But not only not only the cardiac pathologies, also the different surgical procedure that are correlated with the list that we saw before may require in the post-op the treatment with selective pulmonary vasodilation after repair. And using the Aristotle classification, the Aristotle score, we can identify more or less 20 surgical procedures that may benefit from selective pulmonary vasodilation. And those surgical procedure has a higher Aristotle score, mean Aristotle score of 8.5. But consider that the concept of usefulness of pulmonary vasodilation probably is not necessarily associated to perioperative risk profile of pulmonary hypertension. Also, there are tools like ECMO and VAD that may represent other environments for selective pulmonary vasodilation. Regarding the cardiopulmonary bypass effects, we know very well which are the effects of this, and Gerald Bachber and this group demonstrated how in 12 piglets, those piglets that were treated with mercaptopropionylglycine and catalase that are considered antioxidants and preserve the release of nitric oxide, determine a lower level of pulmonary vascular resistance in the post-op period, respect those piglets that were not treated with these antioxidants. So this demonstrates that the impairment in release of nitric oxides determine pulmonary vasoconstriction. And obviously all these are worsened or triggered by what I said before, these conditions that we as anesthesiologists, as intensivists, have to prevent absolutely, have to treat. And we have to stop this circle that is continuing and determine pulmonary hypertension. And what we can do, we have to apply ventilator strategies, as we know, more oxygenation, prevent atelectasis, and so on. We have to sedate the patient, and we have to use also neuromuscular blockage drugs. We need to control the stress response to the surgical procedures and using also a lot of analgesic and anxiolytic drugs. Most common used is morphine, that is the gold standard, is considered the gold standard. Also fentanyl and sufentanil are good choices for treating pain or controlling pain. Use sedatives and use muscle relaxant. I suggest to use the newer muscle relaxant that are less histamine releaser, such as cisatracurium, for example. Again, other drugs such barbiturates, propofol, and so on. But we have to know how common is severe pulmonary hypertension after cardiac surgery, especially in the congenital heart disease patients. Severe pulmonary hypertension is considered a rare event in total, in general, because it accounts less than 5%. However, it is accompanied by severely increased morbidity and mortality. And in this well-done paper by Lindberg, a Swedish group, they noticed that in that center, the pulmonary hypertension patient, the patient that had experienced pulmonary hypertension in the post-op period, accounted for 2.3%, with a high mortality rate in those patients. And this is our experience, last year experience, for example, 433 cases, just only in San Donato Hospital, not in developing country, obviously, no cardiac transplantation, and we treated for pulmonary hypertension 11 patients, that is more or less 2.5%. So we are in according with the literature. This is the all our cases we did last year. And the most representative pathology that is treated in our center, that was treated last year, but in our experience is always, is truncus arteriosus. For patients were treated with inhalator nitric oxide, respect 5 we operated, and 2 total anomalous pulmonary venous return upon 3. So I talked about nitric oxide. We use nitric oxide for treatment of pulmonary hypertension. We have a lot of experience, and we used this from 1990, more or less, 1992. Nitric oxide reached a great consensus, especially in children's. There are a lot of data supporting the use in neonates with pulmonary hypertension, and a lot of data supporting the use in post-op cardiac patients, pediatric cardiac patients, and also a lot of data that support the use in the right ventricle dysfunction in those patients, not only for the treatment of pulmonary hypertension. The main concern is that we give nitric oxide, obviously, in those patients who has an impairment release in nitric oxide by itself. Also, these panelists, these experts, recommend routinely use also as prophylactic in children at risk of pulmonary hypertension, not only to treat pulmonary hypertension. And the dosage of inhalatory nitric oxide is between 20 to 40 parts per million. So how to proceed, which is our strategies, is first of all to identify the patient and the procedures at risk. We define strictly those patients who are not allowed to receive nitric oxide or pulmonary vasodilator for the pathologies. Consider the use as a diagnostic tool in cath lab, obviously. Define the need for pulmonary artery pressure measurement. Consider also specific procedures such as Fontan procedure requiring a strict control of pulmonary resistance. We use nitric oxide, especially in those patients who are under left VAD or under ECMO, for weaning from ECMO. consider the use in heart transplantation, but we don't do heart transplantation in our center, define the dose, and the winning strategies. We use always sildenafil just to wean the patient from nitric oxide. And I explain that after how can we use this. Consider also the setting of good patients, those patients that are growing up with congenital heart disease, so adult patients, congenital heart patients, and also some patients who suffer for restricted right ventricle physiology, because right ventricle must work in very low afterload conditions. So we can use, but we have to think strictly about this. We know that the great majority of the patients that go cardiac surgery may easily sustain the CPB, pulmonary bypass drive, the increased pulmonary resistance. But there are many patients that suffer for this increase in pulmonary vascular resistance, and sometimes it's impossible to wean from cardiopulmonary bypass. Normally, these patients has elevated preoperative pulmonary resistance, and the complete AV canal, for example, truncus, as I said before, are the classical population. Consider the use, as I said, in left VAD, just to let the left VAD working well, because one of the major problem of the left ventricle assist device is that the right ventricle must work well. So we have to put the condition of the right ventricle in the condition to work well, reducing at all the afterload. As I said, we have to know that the right ventricle is correct in work. And right ventricle refractory can reach up to 40% in the patients, in these patients. And sometimes there is no condition for using nitric oxide. So there is a very good interaction between left VAD and right ventricle function, and we know from the literature that we have to consider, as I said, always this. ECMO is the most common form of mechanical circulatory support for pediatric patients, congenital pediatric patients, also for those patients who suffer for pulmonary hypertension that is refractory. We treat with ECMO, and we wean from ECMO this patient using nitric oxide and other drugs such as sildenafil, for example. Another one drug that is very important, and we are using a lot in this kind of patient, is levosimendan. Levosimendan is a calcium sensitizer. It increases the sensitivity of troponin C for calcium within cardiac myocytes. The dilation of pulmonary vasculature is directly correlated by the activation of adenosine triphosphate potassium channel. There are many studies that address the utility, the good function of these drugs in patients who suffer for right ventricle dysfunction and pulmonary hypertension. Not only in pediatric, but also in adults, there is an emergence, a good literature for treating with those kind of drugs, also for treating with nitric oxide these patients who suffer for, especially for right ventricle dysfunction. And again, such as in pediatric population, also for adults, there is there was a meeting between experts that recommend the use of nitric oxide in those patients. Other drugs are approved for treatment of pulmonary hypertension and ventricle dysfunctions, and are categorized here in different groups, endothelin antagonists, PDA phosphodiesterase inhibitors, prostacyclin analog, and there are three different drugs. But most important, in my opinion, most used in my opinion, reading the literature, are the endothelin receptor antagonist. The main drug is bosentan that is used now in adult patients, but also in pediatric population is increasing the use, mainly preoperatively, not for postoperatively, or only for postoperative treatment for this patient. So we have to know who are the patients who suffer, and we have to pre-treat this patient with bosentan. And again, the phosphodiesterase type 5 inhibitors, sildenafil, the most used, is normally used in the post-op, but also there are a lot of papers that address the good use of sildenafil in the preoperative patients to reduce vascular resistance and to increase the best performance of the right ventricle and reduce the incidence of pulmonary hypertension in the post-op period. There are other drugs that are under studies. One of the most promising is the ROCK kinase inhibitor, but I think we need time to study this. The combination therapy is considered the best choice nowadays. There are a lot of trials that address the good results using combination therapy, and probably this is the next future. Well, we have to treat, obviously, arrhythmias. That is one of the worst thing that can happen to the patient that has pulmonary hypertension in the post-op, and the mortality, for example, just only for atrial fibrillation associated with pulmonary hypertension reaches 80% within 2 years. And consider also balloon atrial septostomy in many patients, especially those patients who are refractory to conventional therapy. But this is a chronic consideration, not acute consideration in the post-op. So concluding the key points, the pulmonary hypertension is a common event in patients with congenital heart disease. In general, is not a frequent event, but is common in this setting. And pulmonary hypertension in this patient can be caused by pulmonary arterial or pulmonary venous causes. Nitric oxide, inhalatory nitric oxide, is the best choice in acute care, not alone. We use nitric oxide in adjunction other drugs such as sildenafil. And the combination therapy is very promising, more than a single therapy. We have to prevent developing the events of pulmonary hypertension in the post-op period with early identification, repair of congenital heart disease. And this is the ideal management for this patient. Thank you very much.